All right, intracerebral hemorrhage, continued discussion. Treatment of intracranial hemorrhage. Intracerebral hemorrhage is supportive care of treatment of neurological complications, along with holding all anticoagulation, which makes sense, and antiplatelet medications, including SSRIs. Remember, they can harm the way they can prevent our platelets from coagulating together, which we do not want. Aggressive monitoring of intracranial pressure if evidence of transorbital herniation, significant interventricular hemorrhage, or hydrocephalus, or Glasgow Coma Scale less than 8, meaning these patients are not doing well. They're probably going to be intubated. Intracranial pressure is most accurate measure using invasive devices, and the gold standard being placement of the exterior ventricular drain in the lateral ventricle. Now, if you ever see one of these places, it's pretty, I guess, we'll say the word barbaric is something you would expect, this fancy thing with lasers coming there. When you first see them, first they do is shave the head, of course. They're going to measure for a certain spot. Remember, the neurosurgery colleagues have been doing this for a long period of time, a lot of practice. And basically, they have a form of a hand drill. There are some power ones, but basically just getting a drill like you would get at Home Depot, and you drill in there and you put a device for measurement. Pretty crazy when you think about it. It's pretty, if hydrocephalus is noted, external shunting of CFS may be required if osmotic treatments such as mannitol or hypertonic saline do not work. Remember, hypertonic saline is becoming more prominent than mannitol because the effects of mannitol can affect the kidney function. Surgical treatment, evacuation of hematoma for those with a intracranial hemorrhage with a hematoma greater than 3 centimeters. Neurological worsening or brainstem compression is noted. There is no role for steroids. You want to maintain a blood pressure, we're going to say less than 140. Using medications, you want to avoid nitrates due to increase in cranial pressure. Our first lines are going to be nicardipine, carvedilol. Clavapine can be used, but is more expensive. We're going to use the word money, and has a high lipid level. So if you ever see a clavapine, it is literally, it looks like propofol. It's a big, it's a bottle of a white substance, high fat content. Basal ganglion hemorrhage, contralateral hemiparesis and hemisensory loss, can have homoptic hemiplegia, which is hemioptic visual loss on the same side. So if it's going to be on this side, both on the right side, both on the left side. Gaze palsy, cerebral amyloid angiopathy is going to be second major cause of intracranial hemorrhage. Remember, first is going to be hypertension. It is a beta pleated sheet protein amyloid, which can cause the blood vessels to lose their natural elasticity and become more fragile and bleed easy. Can have multilobar hemorrhages, cortical and subcortical white matter. Usually spares the ventricles and putnam, thalamus, and pons. High risk of reoccurrence because this tissue has been changed. It's inflexible, it's stiff. There is starting to become treatment for amyloid, and we're seeing this in the heart. Let's see if these changes, these newer medications are going to make it better for the brain. This is going to be over time. This is an area of high interest. Cerebellum hemorrhage, no hemiparesis, facial weakness, ataxia and nystagmus, difficulty walking and nystagmus, occipital headache and neck stiffness, can have a severe headache, nausea and vomiting, and vertigo and unsteadiness. Thalamus hemorrhage, contralateral hemiparesis, and hemisensory loss. We teach you these so that way you can correspond with the professionals and understand, so you correspond with your patients. If your patient is telling you they have a thalamus hemorrhage, you should be able to understand what they're telling you. Non-reactive myotonic pupils, pinpointed pupils, upward gaze, and eyes deviated. Pons hemorrhage, deep coma. When you have these, it doesn't go well. And total paralysis, this usually don't do well and usually die. I want to bring you up to the point, we'll talk one more thing, pinpointed reactive pupils and progressive decline in neurological conditions. Let's go back right here. Sorry, let's go back to that. And progressive, there we go. I just want to bring up a thing called the Lazarus sign. And this is something you will see in kind of your patients who are, we'll call them brain dead. So used to show a lot of videos on these online, but a lot of them got taken down because they would show people's face. So this is an example of one I would see is the patient is brain dead, and this was proven to be brain dead in New York State, you have to have 2 neurologists to evaluate a patient and prove that the patient is brain dead, and they have to go through the certain criteria. This patient was brain dead, and they're on the ventilator, but if you touch their feet, they would cross their arms like this, which is crazy. So this became a big issue for the family because the fact is, if you see this, you have to think that the patient is not brain dead. And there's different signs of Lazarus reflex. There's times you can see cases where people are putting their hands on their waist. This is a spinal reflex. It is seen in brain dead patients. This is a reflex left over. The patient is brain dead. In the case I had is they cross their arms whenever they're stimulated. There's different examples of Lazarus sign. I welcome you to look them up online and see if there's still videos available for this. All right, signs and symptoms consistent with elevated intracranial pressure with impending herniation. Remember the old Cushing's response? Cushing was in everywhere too. That's another giant. Hypertension, bradycardia, and irregular respirations. Cushing's response, let's say it again, hypertension, bradycardia, and irregular respirations, and that's why these nurses on the neuro ICUs, they get really afraid when they see that bradycardia or they see changes on the ventilator in a patient that's not sedated. Concern for impending herniation, dilated non-reactive pupils, or asymmetric pupils, okay? No motor responsive, progressive decline in neurological condition. All right, now let's talk about neural shorts of the intracranial pressure. Management of intracranial pressure, that's why these people are in the neuro ICU, is to reduce the intracranial pressure. So we want to maintain our CCP. Our CCP is our cerebral perfusion pressure. It's going to be our MAP, which is our mean arterial pressure, which we discussed. Remember, MAP is going to be 1/3 systolic pressure plus 2/3 diastolic pressure, because we spend 2/3 of our life in diastolic. Goal is going to be 65. Yes, there are studies that can show as low as 60, maybe okay, but 65 is going to be our goal. And the study showing where we keep a higher MAP really hasn't helped us that much. You're increasing the risk of having damage from increased vasopressor support. So let's go back to CCP. It's going to be cerebral perfusion pressure, which equals MAP minus the intracranial pressure. Remember, we drill our hole in our head. The neurosurgeon gets that little drill, like I said, puts a little device in the ventricle so that we can measure the pressure. So we get the MAP from getting usually going to have an arterial line if they're in the ICU, in the neuro ICU. So we're going to put a invasive measurement, or if we can't get it for whatever reason, we have a cuff measure. So we get our MAP, and then we're going to subtract our intracranial pressure. That's going to be from the device that has the little hole on the head with the rod in there. And then our goal is going to be what? We want to have greater than 60, practical target of 60 to 70. So what do we want? What are we going to do if your intracranial pressure is elevated? Well, things we can do is decrease the CSF. How can we do that? The drain, remember this right here, the measuring device, we can drain the excess CSF through, we can either do it through lumbar puncture or through the EVD drain, we can actually drain those out. Or we can decrease the cerebral blood volume. Remember, the brain is a helmet. The brain has about 1,400 milliliters of blood in it. And when we have this, what else can we do to reduce this intracranial pressure? Sedation, decompressive craniotomy, and steroids in some cases can be used. Remember, the brain is you can use hyperosmolar therapy, such as what, 3%, or mannitol is less likely to use because what, it damages the kidneys. I know I'm saying it a ton of times, but this will help you remember this. Medical treatment of elevated intracranial pressure, mannitol, as we talked about. Administration of 1.5 to 2 milligrams per kilogram, IV over 30 minutes. If eminent decline is suspected, 0.5 grams per kilogram every 6 to 8 hours. Hold if the serum osmolarity is greater than 320. So this is where you want to measure the serum osmolarity before you give your dose every 6 to 8 hours. Repeat dose associated with rebound cerebral edema, may cause kidney injury. Hypertonic saline, this is going to be our first line. I know we keep talking about this. Remember, if we need to throw the bomb past this, we're not doing well and the patient's about to die, we can give it a try. It is 23.4% for 20 to 30 milliliters if eminent decline is suspected. 3% saline is target of sodium 145 to 155, meaning that we don't really want to go over 155. Hyperventilation and ventilator is not used much anymore, but here again, the target would be a PCO2 of 28 to 35. Remember, our normal, we'll call it the normal, PCO2 is going to be 40. Short-term stabilization, but associated with rebound, elevated intracranial pressure. All right, resume anticoagulation after brain hemorrhage and mechanical valve. So look at this. So the patient has had a head bleed. When is it safe to restart oral anticoagulants? This is $1 million question. This needs a team approach, okay, and a discussion, multidisciplinary discussion team with the patients and families. So only 2 patients had a stroke within 7 days of stopping. So only 2 patients had a stroke within 7 days of stopping the anticoagulation. Let's go back to that really quick. So the optimal time to resume oral anticoagulation is unsettled. We consider a range of variabilities, including patient age, comorbidities, and intracranial size. Okay, let's discuss transfusion and aneurysm subarachnoid hemorrhage, acute aneurysm subarachnoid hemorrhage, and anemia. When do we want to transfuse? Less than or equal to 8, which is going to be conservative, or then when it's equal to 10, our hemoglobin levels. Liberal, so what happened with this study is liberal red blood cell transfusion strategy did not improve neurological outcomes in 12 months compared to restrictive strategy. This is going on with all of our other literature. Primary outcome was going to be unfavorable neurological outcome, and this was going to be the modified Rankin score. Several other scores were using in 12-month functional outcomes. This was using 742 patients at 23 centers. And basically it showed, like in our other studies with other types of bleeds, is that conservative has been better than a liberal transfusion study. All right, we got a 32-year-old female with facial tingling and fatigue. Okay, that's facial tingling and fatigue. 32-year-old female coming in and has facial tingling and fatigue. All right, let's go to an unfair board question. Which of the following best supports multiple sclerosis according to the 2017 McDonald criteria? Why is McDonald's involved in our healthcare? Oh no, we're not. McDonald's in healthcare. So presence of single enhancing lesion on MRI in normal CSF, multiple T2 hyperintense lesions, at least 2 CNS regions, and CNS specific olecranon bands, history of optic neuritis and normal MRI, a single clinical attack, and absence of olecranon bands in CSF, MRI showing chronic and non-enhancing lesions. So where does multiple sclerosis come from? We'll talk about this. Let's read this question first and we'll talk about multiple sclerosis. It's a 28-year-old female with onset of unilateral vision loss. Remember, I just gave this away. And the pain with eye movement. Neurological examination reveals a right efferent pupillary defect. MRI of the brain demonstrates a multiple T2 hyperintense lesions in the paraventricular and juxtacortical regions, some enhanced with gadolinium. CSF fluids analysis reveals the presence of olecranon bands. Which of the following best supports diagnosis of multiple sclerosis according to the 2017 McDonald criteria? Not the Ronald McDonald criteria, it's the 2017 McDonald criteria. Remember, the Latin term for multiple sclerosis means multiplex. So the term sclerosis comes from the Greek word of hard. So multiple hardened plaques or lesions in the white matter portion of the brain. Multiple indicates these lesions occur in many different systems of the neural system. So multiple sclerosis, multiple plaques. What's the answer? Multiple T2 hyperintense lesions in at least 2 CNS regions and CSF specific olecranon bands. The McDonald criteria are diagnosis of, and we're going to hear this term, time and space. Multiple sclerosis require evidence of disseminated space, lesions in at least 2 characteristics CNS regions and disseminated in time, which can be demonstrated. CNS are specific olecranon bands in patients with single clinical attack. The approach is time and space. Multiple sclerosis, multiple central nervous problems over time lasting 24 to 48 hours, time and space, at least 2 different lesions at 2 different CNS sites, separated by at least 1 month. Knife-like pain is described by patients. What is it? It's an autoimmune attack against the myelin in the central nervous system. It's mediated by the T cell, activated cytokines, B cells, and macrophages. T cells initiate a hyperintensive response. It damages the myelin and oligodendrites. After multiple attacks, the tissue is no longer available to heal. The inflammatory process leaves behind a scar. What would be the equivalent to, say we had scarring on our arm because maybe it just didn't heal right, because multiple times we've been we've injured that portion of our skin, and it comes back with scar tissue. Scar tissue is okay on our skin, it makes us look tough, but in our brain it doesn't go well. We have transient episodes, can have transient episodes of visual disturbances. All right, more discussion on multiple sclerosis. Mean age of onset is 23 to 30 years old. Very uncommon to present over the age of 50. Now look at this. 32-year-old increase of MS after an EBV infection. Epstein-Barr virus. We're going to call it Epstein-Bitch virus because guess what? This sucker is everywhere. This is causing a lot of things, a lot of problems. Even it's going to show up as probably increasing our risk of dementia. Patients had lower serum vitamin D levels and associated with a higher risk of MS. Now just remember, as we get higher in our elevation, meaning from here we have the equator, as we move up towards the North Pole, as we move up, there's going to be less sunlight, and guess what? There's higher preponderance for MS. What is EBV, Epstein-Barr virus, also associated with? This horrible thing. We need to get rid of this guy, okay? Burkitt's lymphoma, Hodgkin's lymphoma, nasopharyngeal carcinoma, gastric carcinoma, and various T cell and NK natural killer cell lymphomas. Epstein-Barr virus has been associated with autoimmune disease, multiple sclerosis, as we're discussing, lupus, and Sjogren's syndrome. This is a guy that needs to go away. And guess what? It's in everybody. And why do some people get affected by it or not? That's the billion-dollar question. Hopefully you and your team can solve this. Optic neuritis kids, visual changes and pain in one eye. The most common presentation is pain associated with movement of the eye. Also noted for transverse myelitis, which is unilateral weakness and symptoms in sensory systems. We'll talk about this in brain stem syndrome with vertigo, dysarthria, and issues with balance. You can have Bell's palsy, which can present and be a presenting manifestation of multiple sclerosis. Current and former smokers have worse outcomes. Multiple sclerosis, continued discussion. We want immune-mediated damage. There's immune-mediated damage to structure of the CNS, showing focal areas of inflammation and demyelination in the white matter tracts. Remember, the higher the latitudes, the further away from the equator is it's suspected due to the vitamin D deficiency and lack of sunlight exposure. Most common demyelinating diseases of the nervous system, the lesions and plaques, are widely distributed in the white matter of the brain, spinal cord, and optic nerves. There's a 50-fold increased risk in a patient, in a child of a patient with MS. So there is a genetic factor. So it's genetic and environmental factors, IL-2, IL-7, in a 25% concordance with monozygotic twins. So this is one. So there's an environmental and a genetic hit. Higher in risk in those in northern latitudes, suspected secondary to vitamin D deficiency and sunlight, lack of sunlight exposure. Optic neuritis is an inflammatory demyelinating condition of the optic nerve leading to acute visual loss. You can have the immune mediates and presents with acute monocular vision loss for hours to days. The afferent pupillary defect, examining the patient who has an asymmetric pupil reacting to light when it's shined back and forth between the two eyes. So we shine the aphares. So the examination, they're going to have unequal pupils. That's why we do those lights in eyes. That's why you look in people's eyes. That's really important. Eyes is a window to the soul. Eyes will stop you from getting sued. Look at their eyes. Look at their eyes, especially when they're intubated on a ventilator. Because guess what? If you have asymmetric pupils, there's only a couple things can do that, and you have to worry, did this patient have a bad outcome, such as a bleed or a change, and that's why their pupils aren't equal. Look in their eyes. Don't be one of those people there. Nobody looks in the eyes in their patients, and then all of a sudden they have what? They have dilated bilateral eyes, they have an intracranial hemorrhage, and they have that didn't get noticed, and then they have herniation and death. Afferent pupillary defect, examination when looking at the patient's eyes, remember look at them, asymmetric pupil reaction to light when it's shined back and forth between the two eyes. You have hyperemesis swelling of the optic disc and blurred, that's if you happen to look in the eyes. Oh, I'm not even asking you to look in the eyes. It'd be nice if we could. There's great devices now that you can use bedside that can help you with that and make it so much easier than the old school ways of doing it. And we're gonna have swelling of the optic disc and blur of the disc margins with distended veins. Associated with MS is 15 to 20% of MS cases are present with optic neuritis. 50% during the course, developed optic neuritis during the course of the illness. So it's inflammation of the optic nerve. You can have vision blurring post-exercise. It can actually cue is getting a hot shower. Hot showers can change things in MS. They heat from there, it causes stress. Stress can do it too. Major presentation is paresthesias. Remember, going back to MS, most common presentations are paresthesias, tingling. Remember, like our case study, sensation, loss of vibration. Also, people say they have a thick tongue. They say, my tongue is thick, thick. Diagnosis, MRI of the brain and orbits with gadolinium. Optic nerve inflammation of ovoid-shaped paraventricular white matter lesions that are greater than 3 millimeters. Noted on MRI. MRI is important for multiple sclerosis.